The topic for today is the Greater Manchester Care Record, which is our local repository for healthcare data, which you'll be hearing all about. So we've got 3 talks lined up today. First of all, Richard will give us a general overview of the GMCR and how we can use it for research. And then we have 2 case studies presented by Lamise and Ruth, who will explain how they've been using GMCR over the last 2 years. So without further ado, I'll invite Richard. So Richard is the Senior Research Data Engineer involved with the GMCR. I'm sure you'll tell us all about what you do as well, Richard, but he'll be talking to us today, giving us a general overview of the GMCR and what it's capable of. Over to you, Richard.
Okay, thanks, Matt. Unfortunately, the audio isn't quite set up, so I need to stand near this laptop, otherwise the people on the Zoom call won't be able to hear me. So I'll try and speak loud enough, but give me a shout if you can't hear me at the back. So yeah, thanks, Matt. As I said, my name's Richard. I'm a research data engineer on this project. What I'm going to do today is cover 4 main topics. So first of all, just what is the GMCR, then what data is actually stored in it, how you can get access to it, and then I'm going to probably spend the bulk of the talk talking about the role of what we're calling research data engineers. This is probably one of the unique selling points of this data where we set it up, and it's useful to understand who the RDEs are and what their role is in the system. So first of all, what is the GMCR? So quite simply, it stands for the Greater Manchester Care Record. So this is it's a shared care record, so data from different parts of the healthcare system which isn't normally together. So for example, data from primary care, your GP, data from hospitals, secondary care, all that data is brought together into a single place. And that's mainly primary care, but that's largely because most of your care record is held by your GP, with just small pockets in other places. It's set up primarily for clinicians, so that if you go to hospital, the clinician can potentially access your primary care record when otherwise they might not be able to. But once you have such a big database, there's then also secondary uses, including research, which is why we're here today. So we have a copy of this database, which is anonymized, so the patient identifiers are removed. Initially, all our research has been COVID related. I think the 2 examples you'll hear later from Ruth and Lamise are both COVID related research. We are beginning to expand beyond this. And I'm going to touch on more about that later. Okay, so that's in what it is, but now what's actually contained in it. So split into who and what. So who, it's everybody who's had any sort of interaction with the Greater Manchester Healthcare Services. So if you're registered with the GP within Greater Manchester, or if you've been to one of the hospitals or had care in a tertiary centre such as the Christie Cancer Hospital, then likely your data will be contained within the GMCR, with the exception of opt-outs. So it is possible for you to opt out of data sharing, and in which case your data will not be going into the shared care record. In terms of what we have demographic data about people. We don't have things like date of birth because they are considered identifiers. So we tend to aggregate up a level to something that's still useful for research, but isn't identifiable. So for example, you have year of birth rather than date of birth. We know sex, ethnicity, LSOA is a geographic location, in case you haven't come across that. And once you have geographic location, you can link it to things like deprivation score, pollution levels, other things like that. We know which GP you're registered with, and we know date of death, or at least perhaps I think we just know month of death rather than actual date of death, if you have indeed died. The primary care data comes from 3 different GP system suppliers across Greater Manchester, EMIS Vision and TPP. We do have acute data, so from hospitals, though because the feeds are different from each hospital, in terms of what we have as like a common denominator, it's mainly around when an admission occurred, when a discharge occurred, on whether that admission was planned or unplanned. So it's not a great deal, but it is better than just having primary care data by itself. We also have other feeds of data, so for instance, a cancer summary set of data from the Christie. Now, one thing we get asked a lot by researchers is, does the GMCR contain X, where X might be a particular diagnosis or a symptom or a procedure? And what we tend to do is sort of twist that question around and say, well, do GPs routinely record X with clinical codes? So as a quick aside, clinical codes are short alphanumeric strings which represent different concepts. So any medical concept you could think of, whether it's a diagnosis, a procedure, a symptom, observation, a medication, a lab test, these will all have their own unique clinical code. And obviously when people use these in healthcare systems, it means we have data that we can actually use in a meaningful way rather than relying on free text. So when you sit with your GP and you tell them about your symptoms you've been having, you sort of think, what does that GP then enter into their system? If they're just entering free text, then we probably don't have that data. But if they're entering as a code, then we might. There's a very rough rule of thumb. We say, well, if it's a common long-term condition, so think asthma, hypertension, COPD, heart failure, diabetes, any of these sort of big hitting common conditions, anything around the monitoring, diagnosis, treatment, we'll have that data and it'll be pretty good. If it's a prescription in primary care, that's all computerized. So your GP will do it on a computer, so that all gets automatically coded. So that's pretty good. And again, lab tests, if your GP initiates a lab test, then they get put back automatically into your record. So they're all places where the healthcare data, not just the GMCR, this is healthcare data across the UK. That's where the strengths are. Beyond that, we don't know. What we tend to do is on a case-by-case basis, we take a look at the data, see how many times these sort of things occur, and then feed back to the people involved to see if that sort of tallies what they would expect. Next is how to access. So if you're interested in doing research on healthcare in any way, so we've got quite a well-defined process. There's a form to fill in. We want you to describe what your research question is. We need you to provide a plain English summary, and these usually get put on a web page, so you can sort of be open about what we're doing with the data. You need to describe the exact form of data that you want. And this is something I'll touch on later on when I talk about the role of a research data engineer. But we like people sort of to say to us, in an ideal situation, what would the data look like that we give you? And so you could describe it, I want 3 tables, and in this table, I want each of my rows to be this, and I want columns representing X, Y, and Z. And that helps us to then provide that data to the researcher. And we also actually describe your analysis methods. And all these will be reviewed either by myself, one of my team of research data engineers, or statisticians like Matt we have on the project, to work out if the data that you want is fit for purpose, it will answer your questions, and whether your analysis methods make sense. So all of this is done in collaboration, say, with a research data engineer, so we help you through the process. But once that's done, it then gets submitted, and there's a secondary users and research group, which is formed of people, various stakeholders throughout Greater Manchester. So you've got representatives from primary care, secondary care, people from the sort of the Health and Social Care Partnership. And they sit once a month and they review these requests and decide whether or not the request is suitable and whether or not to approve it. If it does get approved, then the analysts get provided with a Windows virtual desktop environment. So you connect to it via a remote desktop from your local machine. It then looks like you're on a Windows machine, which has common stats tools like R and Stata pre-installed, so you can then work with the data on that machine. All analysis would then take place within that environment, and any outputs for papers, for example, where you want to take tables or figures or some numbers to put into a paper, then there's an export checking step where the data to be removed needs to be checked to make sure there are things like no small numbers. But there's a slightly big but at the moment. We currently don't actually have a legal basis for extracting data from new studies. Until the end of June, we had what was called the COPE notice, which is where the Secretary of State for Health said, for the purpose of COVID research, we're going to relax all the restrictions on accessing potentially identifiable data. And so until June this year, people around the country were able to access healthcare data to do research related to COVID. That expired at the end of June, and we were hoping to have a seamless transition where we went straight into the new world where we give out data for non-COVID research. But things happened, it didn't quite work out. And anyway, we're currently preparing an IRAS and CAG application to allow the GMCR to be called a research database and to allow people to access it for any type of healthcare research. So we're hoping that will complete relatively soon. But if you are interested in getting data for work and you want to be kept in the loop, there's an email address here. I think the slides will be circulated afterwards. Or you can contact myself or anyone else related to our team. And we can then keep you in the loop and let you know when it's ready. And also answer any questions you might have. If you just want to see if an idea is feasible, even without getting the data itself. So the first half of my talk, I've sort of whistled through what it is, what's in it, how you get access to it. Now, for the remaining part of this talk, I'm going to dive a bit deeper into the research data engineers to just try and sort of explain very clearly what it is we do and why that's a good thing, or at least we think it is for this database. So I'll interchangeably call them RDEs, research data engineers. It's a team, it's led by myself. George, who's in the audience, is one of our members, and we've got 2 other people in the team as well. Now, we've been using the whole of the GMCR database for, I guess, getting on for nearly 2 years now, since we first got permission to access it. So it means that we have quite a good knowledge of what's in the data, what things it's good for, what things it's perhaps less good for. We know where to find different bits of data, and very often, if you want to know if something is feasible, we can probably answer it straight away. Or if not, after a few queries, can probably provide an answer. We also have expertise in clinical coding and clinical code sets. So I talked before about clinical codes and how they represent any clinical concepts you might come across in healthcare. When you want to actually query the database for a certain thing, whether someone's got heart failure or whether they've got a particular blood test or on a particular medication, you find there isn't just a single code for each concept. So heart failure would cover probably quite a variety of sub-conditions. So you need to make sure that when you create your code list of all the different codes that represent heart failure, you need to make sure that's accurate, because if you make mistakes there, then they're just going to, down the line, it's going to sort of lead to potentially going to affect your results. So we have the expertise in how you construct these code sets, how you reuse and share them. We also know how to query the database, so we've got good database skills, and also how to clean data and prepare data and write scripts to do that. We also then create and maintain a common library of all the code, scripts, clinical codes, documentation. Everything we do on every project is documented and it's stored online in a GitHub repository. So that's then open for people to hopefully reuse, or at least if not to scrutinize what it is we're doing. And it means that when researchers publish their work, they can potentially link back to our repository and say, here are all the codes I used, here are all the scripts that we used to clean the data, and here's my analysis code. So in a single line, research data engineers provide data extracts from the GMCR to study analysts in a secure environment so they can answer research questions, whether they mean study analysts. So to further sort of explain the difference between the sort of data that you're going to get in your routinely collected database of primary and secondary care data to the sort of data which people might term research ready, to analyze, I'm going to briefly talk about that. So roughly speaking, this is what primary care data looks like. This is what we would consider to be routinely collected data. Now, this is what I would call a long format. So there's a fixed number of columns. And if you want to add more data, then you add more rows. So every time a person has something happens to them in healthcare, whether it's a diagnosis or just a blood pressure test or a prescription, you get an entry in this table. The event date column, the middle one, will tell you when that thing happened. The event code, this is the clinical codes that I'm talking about. So in this case, this is a dictionary or a terminology called SNOMED. So each of those numeric entries in the event code column would correspond to a different clinical concept. And then sometimes these things are going to have a value or units. If it's a diagnosis of diabetes, there wouldn't be, but if it was a blood pressure reading, for example, then it would have a value in units. So for instance, that bottom row you can see, because the unit is millimeters of mercury, I'm going to guess that is a systolic blood pressure reading. Whereas the second line, which is it's a medication, because you can see there the command from the GP is take 2 each morning. That's one of the things that we sometimes need to deal with, because if you imagine when you actually go to a GP and they give you a medication, the only way that they explain to you the dosage is usually in human readable text, like take 2 each morning. So there isn't necessarily anything stored in the data which tells you precisely what the dose is. And you sometimes need to infer it from how big the tablets are and how many you're being told to take each day, which can get complicated if it's take 2 after meals, 3 in the evening, 2 in the morning. Research-ready data, on the other hand, is typically what I guess you'd call a Y format. So you would have 1 row per patient and multiple columns. If you want to add more data to this, you add more columns, whereas in the previous one, it was long, so adding more data involves adding more rows. Each column would then be potentially some sort of be a covariate and some sort of regression analysis. Here you've got a list of patients where we've got some demographic information, so birth year, sex, a couple of yes/no flags, whether their death was classed as a COVID-related death, whether the person is on a statin, whether they have hypertension, and then maybe this is a cohort of people who've had a stroke, and so there's a column with the date when they actually had their stroke. And you can imagine you could have hundreds of columns here of anything that might be of interest in your statistical analysis. But to give a sort of example of why this isn't that straightforward and why having a team of people who can help you prepare the data is important, is we just consider one of those columns, whether someone is on statins or not. Now, this is something where sort of as a human, you can probably, you know it when you see it, but when you actually try and write down what it means based on the clinical codes, whether someone is on statins or not, it can become quite complicated. So do you need multiple prescriptions or just one? So if I had a prescription 3 weeks ago, does that count? Or do I need to have had 2, 3, 4 previously to show that I'm continually on them? How frequently do they need to be? How regular do they need to be? If I'm picking up a month's worth of tablets every 5 weeks, then that's probably enough to say I'm on it. If I'm only picking up a month's worth of tablets every 3 months, every 4 months, am I on that by just calling it dear to the medication? Or perhaps should I be on it when I'm receiving the tablet and then a month later I'm now off it? So it's not straightforward, and different people may have different definitions of what being on statins means. And as I said before, which clinical code should you use? So statins, there are many different types of statins. There's probably hundreds of different codes, and you need to make sure that you get all the codes for statins to make sure you don't miss anyone. So bringing it back to the role of the RDE. So if we didn't have RDEs, and I'm sure you'll come across some data sets like this where, well, for healthcare data in particular, you would go through certain steps to gain approval for the data, and you would then get direct access to all the data. And that's not great. And as you can see there, all the researchers are feeling a bit sad because they don't really know what they're doing. However, your RDEs, then some of the researchers are a lot happier now. You can tell because of the smiley faces. And this is because we now have the RDE team in the middle. So their queries can go to the RDE team, and it's only us that actually deal with the database in its raw format, and we provide curated data extracts to the researchers. To try and sort of perhaps labour this point somewhat, if we go back to the without RDE situation, the first research team might decide that they need to know whether someone's on statins and whether someone has heart failure or not. Now, they haven't got a common library of code to work with, so they just create these definitions themselves, and so they come up with an is on statins definition and a has heart failure definition. Research team 2 comes along. They also want to know if someone's on statins, but this time they want to know if someone has CKD. The first research team might not have made their code publicly available. They might have shared it in a way that isn't actually particularly helpful to be reused. The research team 2 just start from scratch and they create these 2 definitions. Then research team 3 comes along. They now want to know if someone's on aspirin or not, whether someone has heart failure. Has research team 1 shared that has heart failure definition? Is it something that's portable? Probably not. So they go away and they write it again. They perhaps make the same mistakes that research team 1 did and don't realise it and have to fix it. And a lot of time is spent. So now in the wonderful world where you've got people like myself with the RDE model, we can have this common library of things. So now when the first team comes along, and these examples are the same from the previous slide,
Is the person on statins? Have they got heart failure? We can work with the research team to decide what they mean by is on. And so we come up with our little yellow box, which means whether someone is on a medication. And then we come up with a code list of all the statins. And we give it to the research team one. We then come up with a definition of what has means, because has is going to something that's going to apply to all sorts of conditions. We come up with a code set for heart failure, and then we give it to them. And you can probably see where it's going, but research team 2 come along and say, it's on statins. Because that's great. No, we've got this definition that is on. We explain it to them, and they say, well, actually, that's not quite what we need. We want it to be slightly different. So that's okay. We come up with a different definition of it's on. But we can still reuse the statins code set, so that's a bit saved. We don't have to do that. Has CKD, we've already defined what has means, so we just need to come up with a CKD code list, and then we can provide them with their has CKD phenotype. And finally, the research team 3 comes along, is on aspirin. They're happy to tell them what 2 different definitions it is on, and they say, well, number 1 sounds like the one for us. So we come with a code set for aspirin, and then we give them their thing, and then has heart failure. Well, great, we've already done this for someone else. We explain to their team, they say, yeah, that sounds fine, and we give them has heart failure. And what we tend to find is most research teams, if we say, well, we've already got this definition, they're happy to just take it. And they'll probably review it, but most of the time, people are happy to reuse code that's already there, rather than trying to reinvent things.
Which also allows us to create consistency between studies and allows us for comparison. So this is the last slide. So what we feel the benefits of having this RDE team. So data minimization. One of the sort of principles of good governance at GDPR is that data sets should be minimized to their use. So where you have to give people extracts of data which might be sensitive, to minimize it. By doing this, we don't need to give people access to everything. We can give them just precisely the data they need to answer their research question. I think researchers, well, definitely with healthcare, spend most of the time cleaning and preparing the data, whereas this allows them to miss out that step. So it saves time, prevents duplication. It reduces errors. I mean, we definitely do make mistakes in our team. Like, we make them all the time. We make really big ones. But likely we only make them once. And then once we fixed it, we probably won't make that again. And we've got the code fixed and ready to go. So all studies teams can benefit from that. And also our common library is then publicly available. So that's good for transparency. It allows other research groups to easily review what we've done and to build on our work. And with that, I'll say thank you for listening. I don't know if you want to do any questions now or whether we should, yeah, okay, Matt, you should do some questions now. So I'll open the floor if anyone has any questions.
Any questions? And if you have questions online, just pop them in the chat and we'll find them on our comments.
Most chronic diseases for instance, in my father's state, that is much more severe in the first. It's easier someone's in their first year of life.
So how fixed is it, would you say? Whether you could get one with relatively good justification.
Okay. So could you replace it with 5 first line? Is it first year of life?
Okay. Yes, it's
someone's like taking infants, whether they're 2 months old, 5 months old, 2 months old.
Okay, I'm just going to repeat all the questions for the purposes of the Zoom call. So the question is, for the year of birth, as the anonymization for date of birth, is whether, if say you had someone in their first year of life, whether you could get some sort of flag rather than having the just the year of birth, whether you could have a flag about whether someone was or wasn't in their first year of life to get more granularity. So, I mean, I think, yes, in theory you could. So, for example, one of the things we did was we know someone's month of death, and we know when people have had COVID positive tests. So that means you can't actually work out from that data whether someone's had a death within 28 days, which became sort of the standard measure. But that data is known in the identifiable version of the database used for clinical use. So we work with the supplier who maintains that database, and they just added a new column, which was death within 28 days of COVID. And so, yeah, in this situation, if there was a need to have some sort of flag related to date of birth, but was still anonymized, then that's something that we could add.
Thanks, Thomas. I'll take this online one and then back to the room. So Louise asks, is there a cost associated with accessing and using the data?
It's a good question. At the moment, we say if it's a new project and it's been written into a grant, we ask people to use some of the time of people involved to be added to the grant. However, going forward, when we open it up to non-COVID research, we are going to need to start charging in order to sort of make it self-sustaining. I think it hasn't quite been decided how much, but I guess it's going to be in line with other databases, maybe on the cheaper end, because to some extent, part of this is sort of already paid for out of the devolved GM health and social care budget. So the sort of the hardware aspect is kind of already paid for. And what we're recouping is the time of people like myself who work on it. So it would probably be on the cheaper end of other research databases.
Okay, so next question from Vicky. What's the coverage of the data? So the percentage of GPs that contribute?
It's either 100% or it's 99%. There's at most one GP who isn't currently contributing. So I mean, it's effectively 100%.
Okay. Any other questions from the room? Yeah.
How do you deal with primary care outside of Greater Manchester? And vice versa, for some reason, a tertiary.
Okay, so the question is for people who perhaps receive primary care outside of Greater Manchester, or people who are at a GP in Greater Manchester but who seek secondary or tertiary care outside of Greater Manchester. I mean, in the data, we don't have things that occur outside of Greater Manchester. So if you live in Greater Manchester, but you're registered with a GP outside of Greater Manchester, then unless you've interacted with a hospital in GM, then we just wouldn't have your data. So it is one of the things that we sometimes need to be careful about when we're defining our cohorts. What we normally say to researchers is that we can give you an extract of people who are registered with a GP, because so that's not quite the same as the population of GM. But at least it's reasonably well defined, and it's also the population where we have the most data, because if you're registered with the GP, then we'll have all your primary care data, and because that's where the bulk of the data is. That seems like a sensible way to define a cohort. And then people who are sort of half in, half out. So I guess with the people who live outside, who are registered outside, then we probably wouldn't include you in a cohort, even if you had some hospital data. But if you lived in GM and were receiving hospital care elsewhere, then we'd probably use you in the cohort. We just wouldn't know that you'd had this hospital care outside, and that I guess is just one of the limitations.
You might have some prescription in primary care, someone who's doing dialysis in grade from to.
I guess. So you mean someone who's registered out?
Someone lives in Wilmslow, gets dialysis at MRI, they're trying to tertiary care and MRI. Would their prescription data from primary care contribute to their GM part of their tertiary care?
Are you saying is this for someone who's registered outside of Greater Manchester? No, because we wouldn't get any of their primary care data.
Yeah, I remember in a couple of early studies that I was involved with, this is something we really had to think about a lot, these sort of boundary cases and how to handle it. I don't think there was an easy answer in some of these cases. And so Louise has just followed up. So is it worth contacting you for developing costs associated with data access and time of data engineers?
Yes, definitely. Please do, Louise.
Okay. Anyone else? Or if not, shall we thank Richard again? And next up, we have Lamise. So Lamise Hassan is a mixed methods research fellow. So I've known her for a long time. She's got a very diverse background of skills in both quantitative and qualitative, and PPI and all sorts of other bits. So I think Lamise knows a bit about everything. So it'd be really interesting to hear from her about COVID-19 in people with mental illness. But over to you, Louise.
Thanks, Matt. Yeah, I think jack of all trades. I'll let you complete the sentence. I've stuck a QR code on there. That's just shameless promotion of our paper that's just out. So hopefully it works. But if you do want to look at your phones while I'm talking, you've got a very good excuse if you're looking at my paper. Our paper, should I say. Thanks for inviting me today. This is my first kind of in-person talk in like 2 years. So it's really nice just to be in the room to do this kind of hybrid format, really. So I'm excited to be here. My name is Louise. Like Matt said, my background's in psychology originally. I started off in psychology, then got really interested in data science methods, spent a few years there working around kind of participatory methods. And more recently, I'm getting more specialised in using real world data for research. So things like social media data, wearables data, and also routinely collected health records. And as of the last year, I've just moved back into the psychology department. So I'm kind of more of a mental health data scientist now. So I'm going to talk to you about this project we've used the GMCR for most recently, which is looking at COVID-19 mortality in people with severe mental illness, and hopefully tell you a bit about our journey and how we found using the GMCR as well as the findings of the research. So, okay. So our project aims to investigate differences in mortality, COVID-19 related mortality amongst people with severe and enduring mental illness. And what we wanted to know, basically, were what COVID mortality rates were amongst people with different diagnoses of SMI, how they changed over time, and try and unpick some of those underlying reasons behind why we might be seeing some of those rates. I mean, spoiler alert, there are increased rates of mortality amongst this population. It's not just our research that's picked up on this. We wanted to really try and look at whether these were down to things like demographic differences, underlying illnesses, or things like vaccinations coming into play. So why is this important? Well, we know that people with severe and enduring mental illness already experience much worse physical health than the general population, unfortunately. And that goes for both metabolic and cardio diseases like heart disease and diabetes, but also infectious diseases like TB, HIV, and now COVID. And these can take a significant toll on people, really, over the life course. It's a shocking statistic, really, that it can add up to 15 to 20 years reduced life expectancy on average. So it's really important to be looking not just at the mental health of people with SMI, but also their physical health. So when the COVID-19 pandemic began, obviously there was a lot of concern for how vulnerable groups might be impacted that were already experiencing health inequalities, including people with SMI. And very quickly, we started seeing lots of studies in this area, trying to look at risk of serious outcomes like hospitalisation and mortality. And that's really useful and important in this area. It's not just about counting deaths or counting these outcomes. It's about ensuring that people can act on this data. So as a result of a lot of that work, there were calls for people with SMI to have priority access to things like vaccinations and support and care. So it can be very important to do this kind of epidemiological work. This was a very fast-paced area of research, as you can imagine. It's probably the most fast-paced area of research I've been involved in. Like, it's not uncommon to be doing research and then publishing years later about your findings. But in the last year, we've published 3 papers, and that's been the quickest I've ever had to do this kind of work and work on these timescales. So it was important that we were able to access data quickly. And working with the GMCR, one of the things I will say is that process of getting approvals quite quick. They do it so you have this kind of back and forth between the team. So they'll ask you questions, they'll get you to do a lightweight application first, and you go deeper into the process. It's not like you have to do everything up front and then wait weeks and weeks and weeks for a response. It was quite quick, and that helped us to shape our research quickly, and that was key in getting these results out faster. So very important. When we approached GMCR, we'd already done a similar project in this area using biobank data, and you can find that online as well. But we'd only looked at rates of mortality amongst people before the vaccination programme came into effect. The other thing about biobank, if anyone's familiar with using biobank, it's a cohort study of older people. I think they originally signed up in their 40s and 50s, follows them over a period of years, looks at outcomes, is that it's a really useful data set, but it's quite selective in that it's known to have quite a healthy volunteer bias. So you're looking at people who are likely to take part in research, who like to turn up to assessment centres, give blood samples, take part in research. And so that means that there are some limitations. It's less diverse than you'd want. And obviously it's an older sample. So by working with GMCR, we're able to look at a much larger, more diverse sample and go for that extended period of time, looking at what had happened, not just in that first year of COVID, as we did in the first paper, but after the vaccination programme was rolled out. So what we did is our sample was around 1 million adults overall, including controls. So a nice big sample. We took people who were alive on the 1st of January. Then we asked GMCR for all cases of people with any lifetime history of a number of mental illnesses that we classified as SMI. So that's schizophrenia, bipolar disorder, or recurrent major depression. And that's prior to February 2020. So we're looking at people who already had a diagnosis at some point and then looking at their outcomes over time. And then we tracked them until September last year, which was just before the booster programme came into effect. And you'll see our sample here. It gives the specific numbers if you're interested, but there's quite a lot of overlap between these groups. So one of the things we were trying to do when we did this is think about how we classified which group people went into. And traditionally, there's kind of more of a hierarchical way of doing these things. So often people in the psychiatry world take people with schizophrenia, they'll see it as severity, schizophrenia, then something like bipolar disorder, if they measure that at all, because it's quite hard to diagnose and define. Often they're missed completely from data sets, and then people with major depression. But one of the things that we did is we were working with a public involvement group, and they were adamant that we included people with bipolar disorder because they've been missed from lots of research data sets. So we decided to take a definition that actually used this overlap and accepted there was going to be overlap. But what we did is we did some sensitivity analysis using this more traditional hierarchical format so that we could satisfy both sets of expectations, because otherwise we would have excluded groups. And they would just not be seen in the data set. So these are some interesting decisions that we had to make along the way. Okay, so what do we do for our analysis? Basically, what we wanted to do was plot mortality rates over time by diagnosis, comparing those SMI groups amongst matched controls against matched controls using regression analysis. So these are some of the variables that we defined here. There were other things we looked at. And I will say originally, we wanted to look at hospitalisation as well, but we couldn't get the data quality on that particular outcome. So we're stuck with mortality, which is a harder outcome and more well-defined in this particular case. So a big part of that was defining with our data engineer, George, lots of these variables. And this was really helpful. I can't underestimate how helpful it is to have someone else doing this work and helping to support you and using code sets that are reusable, that are well-defined, that are defendable. Because I have been asked in papers and review processes, how did you decide on who you're going to include in these groups? And it's really strong argument to say, well, we use this code set that has been developed for this purpose and has been used in all these studies, and you can reuse it. And here's all the codes, and here's the website where it's on. It's so much simpler. So I really believe this is the way forward, as well as the extra support with data validation and cleaning the data as well. So a couple of things we did to try and improve our analysis. We used, because the GMCR sample is large, we could include lots of different covariates. So you'll see there's lots of different measures of the comorbidity on there, several demographic measures. And what we did is produce crude risks, so unadjusted for these estimates, just to find out that crude risk of mortality compared to controls. And then we adjusted for all these different factors to try and start understanding what these factors were that might be attenuating those risks, what might be responsible for the increases. What we also did is every month we calculated vaccination status for each individual. And we also reduced our denominators, so our population reduced over time to account for people who died from COVID and other causes. So it was quite a complex analysis. Unfortunately, you can only do it on a monthly basis, so it does mean you can't do those really fine-grained time-to-event analysis unless, I guess, if you ask for that data in advance, maybe it'd be possible to say, can I have the time and days from this time to this time? But that wasn't something we anticipated doing, so we had to stick to kind of coarser-grained monthly analyses. Right, so some results. So just to give you a flavour of what you can do, really, of this kind of data. So this graph here shows the mortality rate over time due to COVID from March 2020 through to September 21. We had to omit February because we had not enough cases. That's an important part of GMCR. You've got to keep checking that you've got the right numbers and that you can only disclose data that's safe to do so. And you'll see here there's a few things that are really obvious. So we had about 5,000 or so people who died due to COVID-19 up until September last year in Manchester that we had in our data set. You can see there's clear peaks in mortality rates in all groups. First, you can see that first one in April and then later on around winter, which corresponds with what we know about COVID, yes. The second thing you'll see is that purple line. So that purple line represents people with schizophrenia. And that is much higher, those rates are much higher throughout compared to our pooled controls. Also, people with bipolar disorder, you can see in the red, they're also quite clearly elevated. And I think what you can also see a little bit there is that line where the vaccination rollout began and start to see a decline across all groups. So that was a significant linear trend after that point. So you can see that there seems to be an impact there after the vaccination program is kicking in. This graph shows deaths due to other causes, just for reference point, really. So we saw 5,400 deaths, I think, previously. In that same period of time, you can see there's over 14,000 deaths in this population due to other causes. Now, there's a couple of interesting things about this one. So you can see that peak at the start, and that's probably misclassified deaths, we'd be guessing, that are actually perhaps due to COVID and not other causes right at that point in time. So it could be there. But you can also see that pattern, that same pattern emerging with people with mental illness. So people with mental illness are still more likely to die from other causes as well. So this risk of COVID is an added kind of inequality here. It's an added risk going on to people's already elevated risk of mortality, if you can see it for other causes of death during that same period of time. I haven't got the graph here, but what the paper shows, it converts this into a relative risk. And you can see that the relative risk throughout is quite stable amongst deaths produced from other causes. So the way that we're interpreting that is that COVID is an added risk on top of those existing risks. That's not basically deaths that were waiting to happen, or other deaths aren't compensating for that particular purpose. It's not the focus of our research, and other people have done it in much more detail than us, but it is an important part of the story, I feel, to point out. So this table shows overall, taking into account that whole time and the matching process and all these other variables, the crude and adjusted risk ratios for COVID mortality for these three different groups compared to the matched controls, if you look at that as overall. And what you can see in that unadjusted column there is that the main finding is that COVID mortality rates are significantly higher across all three groups of people with SMI, and particularly so amongst people with schizophrenia or bipolar disorder. So you can see they're 3 times more likely to be dying from COVID compared with their age, sex matched controls. When you adjust for those other variables, when you take into account their pre-existing conditions, vaccination status, other variables, it does reduce somewhat, but it does remain significantly higher amongst those two groups, amongst people with schizophrenia and bipolar disorder. It's less clear-cut for people with major depression. It doesn't quite reach that threshold, but you can see the pattern there, can't you? And when we did look at that sensitivity analysis, so when we changed those groupings slightly, these findings held true. So this isn't just an artifact. Those people with bipolar disorder, it's not just because they may have also had a diagnosis of schizophrenia somewhere along the way. Even when you take into account that harsher kind of definition, they still have an elevated risk too. I think this shows it, same point, but a little more clearly, really. You can see that difference between the accrued and adjusted risk ratios, really. Even after that adjustment, you can see how they're elevated. And what we've done in the paper as well, we've got the findings, we've got a fully adjusted model in the paper, and you can look at the individual variables that actually contribute to those changes and look at which ones have actually play a part, including things like vaccination status, which seem to be significantly associated in reduced risk. So there's lots of interesting detail in the individual paper that you can't see here. Something we're able to do along the way as well is that we're able to quickly, we wanted to look at vaccination rates, we wanted to look at vaccination status. So quite early on in the process, we managed to publish a paper in World Psychiatry, which is the #1 psychiatry journal, back in January, looking at vaccination uptake amongst people with SMI. So this table here shows COVID vaccination rates on June the 30th. And if you remember, that was just after the so-called Freedom Day when COVID rules were relaxed. So we were looking to see how many people were vaccinated ahead of that easing of restrictions amongst people with different diagnoses. And what's interesting there is that you can see that people with SMI were significantly more likely to be vaccinated than other groups. But there's a clear difference by diagnosis. So you can see people with affective disorders such as bipolar disorder, major depression, other depressive disorders, they seem to have higher rates of vaccination compared to people with schizophrenia. People with schizophrenia are probably remarkably close, though it's significant, to people with no mental disorder. So you can see it's 69.6 versus 68.4%. So what does that really tell us? Yes, it's significantly higher, but to me, that says that there's a significant proportion of people who are at a higher degree of risk of outcomes, poor outcomes, that are not vaccinated at this time. And that begs the question, why? We also looked at refusals. Now, this is cases where there's a clear refused vaccination code being recorded in the record. Now, how reliable this data is, how well recorded this is, we don't know, but you can see they're much higher, again, twice as likely amongst people with schizophrenia than people with no mental disorder to have a refusal vaccination recorded in the records. Not quite sure what's going on here. It could be that people are being actively approached for vaccination and that the healthcare professionals are recording that in the records. So rather than a haven't got round to it yet, this is an actual decline being recorded. So is it just more likely that this group have these records recorded there? So it's a complicated picture, but some interesting data nonetheless that gives us a clue. Are there reasons why these particular groups might not be able to or might be refusing vaccination at this point? And I think that warrants closer attention. So what did we learn? Well, we learned that the risk of mortality was much higher amongst people with SMI. And these pre-existing conditions were partly, but not wholly, due to some of this excess mortality risk. Vaccination efforts do seem to appear to have reduced that in some respects. But our take-home message really is that these health disparities still remain for people in terms of COVID-19, for people with SMI, even after the vaccination campaign has taken place. That might seem an obvious message, but it's not. It's clear that it's not enough to reduce this risk amongst these populations. We still need to be supporting them and looking after those physical health inequalities. In terms of using the GMCR, there's lots of the usual limitations to using routinely collected data, but using GMCR has got lots of strengths. Over and above that large data set, you've got that support, you've got that RDE support, which makes your life 10 times easier as a researcher and gives that extra veneer of kind of checks and validation. There's transparency and security in this approach, and you have that kind of benefit of being able to work in a secure environment and being more certain about how your data is flowing, that people are checking that there's a procedure about this process. Of course, it is only GM data, although I've not really been challenged about that in papers because we've just seen the numbers and people have been more impressed with the size of the data set, to be honest. So that's not been a problem, provided you acknowledge the limitations, I will say. It doesn't lack some of those fine-grained analyses, and you have to adjust it and cut your cloth to what data is actually there. And of course, you've got to remember you're sharing resource with other people. So I'm sure I wasn't Ruth's favourite person sometimes when I was running really data intensive analysis and kicking her off her virtual computer. And we didn't really know that we were doing that at the same time. So there's a bit of managing of computational resources that needs to be done. Hopefully those issues will be ironed out in future as well. But yeah, overall, it's been a fantastic data set to work with. And it's allowed us to make some really clear kind of implications for services. So what we're saying going forward is this just adds support for the argument that people with severe enduring mental illness need to be offered physical health checks as well as checks on their mental health and suitable interventions. That we need to be recording and trying to acknowledge where health professionals have been recording their attempts to discuss vaccination with people where they're eligible, if we're to understand some of the barriers to uptake in this particular group. This research wouldn't have been possible without lots of people, including our lived experience advisory panel, the GMCR team, and all these people on the slide. There are a couple of papers that have been out, so if you're interested in those, have a look or contact me directly for further details. Thank you very much.
Any questions? Again, any? Oh, there we go. So Emma asks, how was died from COVID defined?
Oh.
Well, the further clarification, that's just some suggestions on how it could have been defined. Was it primary cause of death or death within 28 days of positive test, for example?
This one, I think we did have the death within 28 days of positive test. So that was the main outcome for this study.
Right, any questions in the room? Yeah.
Okay, so the question for people listening in is, did we look at, were we able to try and identify what some of the reasons for the increased mortality were amongst people with schizophrenia, like whether it was comorbidities, etc. Yeah, so in our model, some of the things, it was clear that some of the risk appeared to be explained by the factors that we could measure. You've got to remember that these are quite crude measures, like whether you've got diabetes ever, whether you've got chronic kidney disease ever, so it doesn't really take into account severity of your condition. But it was clear that a lot of these comorbid diagnoses were accounting for some of that excess risk. So it does certainly look like people with particular conditions, such as those COPD, even things like learning disabilities, were accounting for some of the excess risk that we were seeing. So pre-existing conditions have to play a part. Vaccination as well seemed to reduce people's risk. That was definitely part of the puzzle. But this is one of these fundamental questions, really. It's trying to understand whether it's trying to unpick whether it's something that's pre-existing, or whether it's something associated with mental illness itself, or it's treatment that might be responsible. So a lot of people have been looking at actually psychotropic medicines and trying to look at if there's a association between particular prescription types and the risk of COVID. And there's this idea behind the kind of immune kind of inflammatory response, like hypothesis, that there might be, and there's some really interesting work there. We didn't look at it because I didn't feel that we had the fine-grained data enough at that point. We'd really need to dedicate a full analysis to this. Didn't look at it in that level of detail, but some really interesting work looking at things like antidepressant and antipsychotic use. And actually people on antidepressants in some cases have a reduced risk of poorer COVID outcomes. So it seems to suggest that there might be some kind of pathway that's going on there about how immune and inflammatory pathways are operating in people with mental illness that might contribute to their risk. So I think you can see some of these biological differences. And also on top of that, some of the socioeconomic factors. So we measured a bit, like we looked at the index of multiple deprivation and looked at some of that in a basic way. But it could be people with mental illness are more likely to be in conditions that would be more germane to becoming infected with COVID, so living in closer spaces, not being able to isolate, having to go to work in conditions that are perhaps less than ideal. So I think it's a cluster of things, and we managed to measure some of that, but not everything.
Comment.
Well, I was thinking about the last point, which is that just for infections, you have the exposure risks as well as like you have like two components to the risk, exposure, conditional exposure.
Yeah.
And that's been the kind of English thing to take apart, because you see that people like teachers have a higher aggregate risk. Their risk is probably lower conditional exposure than some teaching. Other people potentially have to be like doctors and people without. They're coming up with worse COVID outcomes. And there's some people who also don't have the power to do that. They're also going to social distance. Yeah. So it's a question. How much do you pick up those like how many GPs on the lenses? That's what you start to just
So what we had, I mean, might be something the data engineers can help with, is all I used is ID decile. I think it was decile, not quintile for this one, wasn't it? Was it decile? So all we had, and that's based on, I think, of the postcode where the GP practice is based. That's pretty, is that correct? Probably no, yeah, I'm getting a few nods. Patient, even better then. So that's good. At least we have the patient level IMD decile, but that's pretty, that's not ideal. So there is some of that. But I think what you're saying is really interesting. So when we've looked at, in our previous paper, when we looked at, so we tried to look at that, kind of separate those two risks by looking at outcomes amongst people once they've been hospitalised. And you see even there, amongst people with schizophrenia, amongst those that have been hospitalised in the biobank data set, 50% at the time went on to die from COVID. And that was much higher than the other groups that we were seeing. So once you have COVID, it gives you a clue that there's something else going on there that's kind of independent of that risk of getting it. So if you can split it up along that pathway, it's really useful. Unfortunately, we didn't have that level of data to be able to do that and split infection, hospitalisation and mortality on this occasion. But I think it's, yeah, you have to look at both parts of that equation.
So another question from the in the ready brown coat.
Yeah, we have. Yes, could we get ethnicity data? Sorry, I'm
perhaps Ruth could talk about this.
Yes.
Yeah.
Should we leave that one for Ruth? We did use it, and it wasn't. We did have to impute a lot of missing data for that particular variable, but we did take it into account.
I'm saying it.
Yeah, my question is, data did you have in this variable? So are any studies showing that, let's say, ethnicity conditions that if you had the data for
I think again, is this something you're going to cover, Ruth? That you're going to look at some of this? Sorry, this was a question about ethnicity data and COVID for the people watching. It is. You have to account for it. We did account for it, so we used multiple imputation to look at missing data. I think it was around 20%. So it was quite high enough for us not to just cut it out and leave it. So we did have to do that and take it into account in some way. And it wasn't just a case of doing BME other, which you have to do in some data sets like Black Biobank, which is less than satisfactory at the moment. So that's again one of the kind of advantages of using such a large data set like GMCR.
Okay, final question from Andy.
Sorry.
One clarification question. So the clarification, if you look at the matching controls, I wasn't sure that you were matching them at the time of January 2020 and their status then, whether it was at the time of the COVID event.
At the time of So it would have been 31st January at that point in time, year of birth and gender. Sorry, I missed that. Just so the only time varying nature the only ones that we used was vaccination and death status. Everything else remained constant. So we did vary them for vaccination, but all the other variables like ethnicity obviously would have stayed stable. The demographic ones, so it would have been the comorbid conditions. So if someone developed a new comorbid condition during that period, we wouldn't have picked that up. It was everything that was pre-existing from January. Does that make sense? Or are there other things that you were thinking about? Oh yeah, yeah, they were removed from the data sets. The denominator reduced every month, so we had 18-month periods. So each month we calculated numerators and denominators and had a data set separately for each of those 18 months. So if someone died in January, then or a control or a case, then they wouldn't appear in the February data set and the denominator would be reduced accordingly. If they, yeah, okay.
Okay, let's take the meeting aid.
Okay, so while Ruth just finds her presentation, just give an introduction. So Ruth is a research fellow based here at the University of Manchester, and she's working on the NIHR ARC, so the Applied Research Collaborative Greater Manchester. It's all about how we can translate research into practice. And Ruth's particular interest is in ethnic inequality and other kinds of inequality in healthcare, and she's going to talk to us specifically today about ethnic inequalities in vaccine uptake. So over to you, Ruth.
Thanks very much. I'm fairly cold, so I promise it's not COVID. But if you can't hear me, tell me and I'll try and shout up more, but hopefully my voice is going to be all right. So yeah, thanks, Matt. And I'll just get started. So, I mean, this hardly needs any introduction at this point, but just a quick overview of kind of the COVID vaccines and the rollout. So the rapid development and then mass rollout of the COVID vaccines has been hugely successful in preventing severe COVID illness and mortality, despite these ongoing waves of mass infection. But something we all also know about at this point is there have been inequalities in the uptake of COVID vaccination, same as there are inequalities in most types of preventative medicine and most new healthcare innovations. So relatively early on, it became clear from kind of national evidence that the uptake seemed to be lower in more deprived areas and amongst some ethnic minority communities. And of course, that was also of particular concern because that was also where in the first waves before vaccination was available, we were already seeing higher mortality. So this looked like it could be going to stack inequality on top of inequality. And of course, with kind of the threat of ongoing waves of infection, this could leave some communities particularly exposed to like really high risk of future severe COVID outcomes. So it seemed kind of really important to try and understand how this was likely to play out at the local level and to try and kind of understand how this might look in terms of inequalities in Greater Manchester. So our goal was to look at inequalities in vaccine uptake between ethnic groups locally. So a little bit about our study population then. So this has been kind of discussed already, but we were looking at people living in the community in Greater Manchester who are also registered with a GP in Greater Manchester. So that's kind of the restriction that we added to must have a GP there. And then we were focusing on people who are eligible for priority vaccination. So that was people who are aged 50 plus, or also younger people who had specific health conditions. And this has kind of already been talked about, but this, for me as a researcher, was one of the real advantages of working with the RDEs as kind of the go-between to the GMCR data, because all with specific health conditions, to me, I was like, oh, there's a GCVI information from the government that says it's people with these conditions. And then magically, Richard was able to turn this into something that was could be kind of operationalized. And I think I don't have that kind of experience at all. And I'm not sure we would have been able to achieve that if it wasn't kind of with this great collaboration between the two types of different teams. So with that kind of population, that gave us almost 1.1 million individuals. So again, it is a really large data set, and it lets you do some kind of more granular analysis, which is great. So we're doing this relatively early on in the vaccine rollout. The study period that I'm going to talk about today went up to mid-April 2021. So we're focusing just on first dose of the COVID vaccine. And in that time period, most of the people who were eligible, so 84%, did receive a first dose of COVID vaccination. In terms of the demographics, this has already kind of come up today, but in terms of ethnic groups, the data was actually relatively complete compared to other data sources. So it's not perfect. It was about 12% missing in our sample. But kind of the reason for that, and the reason that it's better than it often is because with the GMCR, they're able to triangulate between kind of the primary care record and also any secondary care records. And ethnicity is often a bit better recorded in secondary care. So that's able to kind of fill in some of those gaps. And I think overall, if you look at the whole population, the missingness for ethnicity is a little higher than in our group. But because we're working with a population who are, I guess, more likely to have interacted with secondary care, then it was actually relatively complete for us. So in terms of the groupings, it was almost 80% white British. And then in terms of the population from ethnic minority backgrounds, using kind of the UK census groups, the largest groups were Pakistani, other white background, other ethnic group, and Black African. So getting into the actual results then. So first we estimated inequalities in COVID vaccine uptake between ethnic groups, looking within each of the vaccine eligibility groups that were specified by JCVI. So you perhaps remember, but there were two based on clinical risk. The highest clinical risk was people who were asked to shield during the first wave. And then there was a moderate clinical risk group. And then other people are eligible in 5-year age bands. So I'm showing these eligibility groups along the bottom of that heat map there. So within each group, we ran separate Cox proportional hazard models, and I'm showing the hazard ratios here. So in each case, the reference group was the white British group shown at the top there. And you can see from this colour scale, so anything in the lighter yellow colours reflects higher uptake than the white British group, and the darker blues into that purple indicates much lower uptake. So kind of the takeaway from this heat map overall is that clearly there were really wide inequalities in uptake between ethnic groups, and that's across each of the eligibility groups. There was particularly low uptake amongst Black African, Black Caribbean, other Black background, and Arab groups. And some of the widest inequalities were amongst some of the most vulnerable groups, so in the oldest age groups and in the high clinical risk groups. And I think I just also wanted to highlight, if you look at the heat map, although there are these wide inequalities for most ethnic minority groups, there's also quite a lot of variation between different ethnic minority groups, which I think is also really important to understand and kind of recognise. And I guess, again, that's where working with a data set like the GMCR, where you've got large numbers and relatively complete ethnicity data, it allows you to do that kind of more granular analysis rather than using the perhaps less helpful groupings like Asian, British Asian, or even like BAME, that kind of catch-all, which I think often kind of masks the true extent of some of the inequalities. So alongside that kind of statistical analysis that we were doing, we also worked with a group of public contributors from diverse communities across Greater Manchester, and they were able to share some really important insights into some of the context behind these inequalities. So we ran a series of online discussion groups, and we heard, a whole range of different concerns about the vaccines and a mix of positive and negative attitudes, and a lot of people who were kind of largely pro-vaccine, but all had some, concerns about the new COVID vaccines. So, there was a range of things, for example, have they been sufficiently safety tested? But also logistical issues, like some people were struggling to access vaccination even though they would like to take up the vaccine offer. We also had quite a lot of discussion around kind of themes of mistrust and distrust of the government and kind of why the vaccines were being pushed so hard. And also just some, stress and anxiety about how politicized the decisions over whether or not to take a COVID vaccine had kind of become. So that's, I'm trying to give a flavour of really what was a really quite wide-ranging discussion. But I think something that really stood out to us is that all of these factors are really specific to the COVID vaccines. What we weren't really hearing was kind of more general anti-vax sentiment. I think there was a lot of discussion in the media about kind of anti-vax and whether people were already against all kinds of vaccination. But that wasn't really what we're hearing. So it made us wonder if also these inequalities that we're seeing might also be specific to the COVID vaccines themselves, as opposed to routine vaccination. But actually, when we tried to look at whether there's any information available about ethnic inequalities in uptake of routine vaccination amongst adults, there really isn't very much known in the UK. So we went back to the GMCR teams and kind of said, we've had this feedback, we're thinking again about what we might want to do, having talked to some public contributors. And we had the flexibility to be able to say, can we add in some more variables for routine vaccination and kind of widen the scope of the analysis? And again, as a user of the GMCR, that was absolutely brilliant, both to be kind of encouraged to do the public involvement engagement, which was facilitated by the connections with Health Innovation Manchester and the ARC, and then also to be able to kind of come back and make it a true iterative process with involving the public and then responding to that and kind of changing the scope and quite quickly and easily moving forwards with a new data extract. So to compare to routine vaccination then, we decided to focus on flu vaccine uptake because very similar groups of adults to those who are prioritised for COVID vaccination are encouraged to take up a free NHS flu vaccine each winter. So it's slightly different as people are over 65 and with certain health conditions, but it's a relatively close overlap. So what we did was we then restricted to the population to those who would have been eligible for a flu vaccine the winter before, and then estimated a kind of summary adjusted inequality. So this is now everyone included, but adjusted by age group and clinical vulnerability. So I'm showing the results for COVID vaccine uptake in the grey, and then in the blue, that's flu vaccine uptake in the previous season. So the main takeaway from this is that COVID vaccine uptake inequalities were much wider than those previously seen for uptake of the flu vaccine. And I think it's worth noticing that for some groups such as Pakistani, Bangladeshi and Chinese, there were these really large inequalities in COVID vaccine uptake. But actually uptake of flu vaccine had been either almost identical to, or in the case of the Bangladeshi group, a bit higher than the white British group previously. So I think, again, it really fitted with what we felt we'd heard from public contributors. And it really does beg the question, what has been so different with the COVID vaccines and perhaps the way they were rolled out that's led to these really much wider inequalities? So as well as this kind of more general analysis, we thought we could maybe learn a little bit more about where these inequalities are arising if we kind of looked at, for each person, did they take up one, the other, or both, or neither of the flu and COVID vaccines, and try and understand a bit about that kind of person by person. So just to kind of benchmark this, before the pandemic, that previous winter season, uptake of the flu vaccine wasn't actually that high. It was about 55% of people who were eligible took it up. But then within that group of people who did take the flu vaccine, uptake of the COVID vaccine was then very high. So 95% of those people then got vaccinated for COVID the following year. And then amongst people who didn't get the flu vaccine, uptake, as you might kind of imagine, was somewhat lower, so about 70%. So this kind of feels intuitive, but it's worth thinking just for a second about some of the possible reasons. So it might be that, it might be to do with how people perceive their risk from respiratory infections. It might be that if people have confidence in one vaccine, they have confidence in vaccination more generally, or if they face barriers to accessing one type of vaccination. Again, that perhaps applies again a bit more generally. So what we did next is to then split the population by whether they had taken up the flu vaccine or hadn't taken it, and then re-estimate ethnic inequalities in COVID vaccine uptake. And what we found was actually that there were really wide inequalities in both of these subsets. So there was both lower COVID vaccine uptake amongst ethnic minority groups, despite having recently had their flu vaccine, and disproportionately higher uptake in the white British group, who hadn't previously been taking up the flu vaccine offer. So again, this really reinforces the fact that we do need to understand what is different about COVID vaccination that's led to this different either access or decision-making about the COVID vaccines compared to kind of how people were approaching flu vaccination the previous season. So of course, a big question behind all of this is what is driving these different inequalities then? And of course, we don't have all the answers at all, but we were able to, again, work with our community advisory group of public contributors and kind of get some insights that I think point to some of the issues that have been different with COVID in terms of vaccination. So Basma was one of the members of our community advisory group, and she was able to talk a bit about some of the experiences of the Syrian community locally in Greater Manchester. And she said there has been a lot of suspicion and concerns about side effects, and particularly related to fertility. And she felt that a lot of this had been kind of due to sharing of misinformation and disinformation on social media, especially things that that weren't translated into English. So kind of where there were gaps in the communicated information from the government, people were kind of sharing more information in other languages. And I guess it's kind of seeing the importance of translating early and getting messages out before misinformation fills some of those gaps. But I think she also was kind of keen to say that really the experiences of discrimination and racism during the pandemic have felt really heightened and really, really more than before. And I think that has perhaps led to increased feelings of marginalisation and more distrust of kind of this government push for vaccination. And I think also important to note that she said a lot of particularly older community members, some of them had wanted to access vaccination but had struggled to do so. So again, thinking about language and IT barriers that have kind of shaped whether people have been able to take up that offer and how quickly they've been able to take up that offer. Nick was also one of our community group members, and he was able to talk a bit about some of the experience with the Jewish community locally. And he said that there had been a lot of initial mistrust, and again, part of this to do with social media and sharing of misinformation. But he said that also actually, as the rollout had gone on, there's been some really great partnership working with kind of local organisations and faith leaders, working with NHS teams and the local council. And in fact, there was some kind of bespoke vaccination sessions run by Hatzola, the Jewish ambulance service. And interventions like this have really helped to increase confidence and to gradually increase uptake. So that work has also been followed up with some kind of more in-depth interviews and focus groups. And that's work that's led by my colleagues, Caroline Sanders and Stephanie Gillibrand, and hopefully we'll be kind of providing some deeper insights soon. So just to conclude then, we found really wide ethnic inequalities in COVID vaccine uptake that were much larger than previous inequalities in flu vaccine uptake. These inequalities existed even amongst those recently vaccinated against flu, and I didn't have time to get into it today, but they also persisted when we restricted the sample just to looking at the most income-deprived areas. We heard insights from public contributors that suggested a mixture of barriers to accessing COVID vaccinations and distrust, kind of stemming from kind of long-term failings for some communities and negative experiences of racism and discrimination had all contributed to lower vaccine uptake. Looking forward, obviously, there's a need to better understand these inequalities and what could be done to reduce them, and to work in partnership with communities to try and kind of address these barriers and also just build some long-term trust. So finally then, I just want to thank, obviously this has been a big team effort, so everyone on the research team and the Jumper and the GMCR teams. Huge thanks to our public contributors who've been absolutely brilliant working with us throughout the project, and the PCIe team who facilitated all of that work. And thanks to you for listening.
So I think there's a couple of comments there from Louise, which you can see. So she says historical medical racism and fears about unethical experimentation on Black people also played a huge part in African and Caribbean people's hesitancy. And there's also the issue of the hostile environment in healthcare in the UK, migrants being dissuaded from using the NHS, for example, through charging regulations. And then all of a sudden, when the vaccine was rolled out, we're expected to use NHS services. So just some useful additional thoughts there.
Yeah, thanks, Louise.
Yeah.
How did you choose when to stop the clock on time to vaccination?
Yeah, so in the initial analysis, where it was split by eligibility group, obviously that's less important, and we did some sense checking that the curves did all start at the dates we thought they should start based on when vaccination became available for each group, and that seemed to fit pretty well, so I think that wasn't an issue. And then in the adjusted analysis, what we did was we started the clock for everyone at the first day of vaccine dose was given, but then we had adjustment by eligibility group, so it was adjusted for, but everyone had the same start of the clock, if that makes sense.
Actually, when you've got people who are overlapping groups, they've got comorbid conditions or they work in healthcare, they're going to stop the vaccine before their cohort was otherwise eligible.
Yeah, so you're right about healthcare workers, and we didn't have any flag for that. So we just, honestly, we could kind of just sense check and be like, what percentage of people are getting vaccination before we think they should have got it based on their eligibility group. And it was a relatively low fraction. So I think it will have been noise in there, but I think it shouldn't have affected things too much.
Okay, and there's a question online from Emma. So when patients get their flu jab at the pharmacy, is that fed back to their GP and therefore included in the GMCR?
Yes, so lots of people will have got their flu jab at a pharmacy, and I think that is one of the differences. It's much more flexible and kind of convenient for a lot of people, the way that you do get a flu jab traditionally. But all of that will appear in your primary care record, so it should all be there regardless of where you got it.
Okay, any other questions? Okay, so let's thank all of our speakers again. So thanks to everyone for joining, both in the room and on Zoom.